Hi there, I'm Gabe Drapos, Chief of Staff at Pearl Health, and I have with me Dr. Vinod Mitta, advisor to Pearl, and our president, Ankit Patel. And we're going to talk a little bit today about some of the novel care measures the direct contracting program from CMS has introduced. Specifically, I want to talk to both of you about the value of pairing capitation with risk exposure and quality measures, and how that maybe differs from other value-based care programs that CMMI has tried in the past efforts of capitation in especially the HMO context in the 90s, where some of that floundered. So would just love to kick that off with your thoughts.
You know, I think what happened in the 90s is you put doctors on capitation, and for lack of a better way of describing it, once you got your fixed PMPM, you're just basically hitting the golf course every day at 3 p.m. And, you know, once that world happens, you know, there wasn't a lot of data, there wasn't an infrastructure to be able to manage and keep doctors accountable now that they're getting a fixed salary. And so insurers kind of thought that the whole thing ended up being a mess, where we're just kind of giving fixed money and guaranteed payments to doctors, but not really getting anything in return. You know, you fast forward to like the 2010s, and we've all been talking about value-based care. And, you know, the consistent issue has always seemed to be this approach where I have to do something today, and then I will get rewarded and paid for it, you know, 18 months down the road. And then, you know, you're sort of sit there asking, well, how do I make my payroll today? How do I pay for my care managers? How do I pay the nurses? How do I pay for all the services and support that help me generate those better outcomes in the first place? Sorry, I got a little fire truck here. So you know, the world that we live in today, a lot of the shortcomings of value-based care programs have been around models that don't really provide for, let's call it upfront capital to pay for the new models of care that physicians want to deploy. I mean, interestingly enough, the best testament to this is there was actually a program that CMS created called the Advanced Payment ACO model, where there was an upfront capital investment made into rural and physician-based ACOs that gave them the capital to pay for additional nurses, care managers, care coordination services. And then that upfront capital was credited against the shared savings that they generated on the back end. It's actually one of the most successful ACO models that CMS has run. And I think it's a testament not necessarily to the model itself, but just this notion that in order to do value-based care, there has to be some recognition that there is capital cost upfront, and there needs to be some financial stability so that doctors can now focus their time on the risk part of their business rather than having to run the two at the same time. But
previous efforts weren't as centered on the physician and giving autonomy and financial independence to the physician to practice. ACOs, HMOs were ultimately larger groups, administratively driven, and it's hard to get that culture of risk-taking when it's offered at the administrative level down to change the behaviors and the mindset for an individual practicing physician. Hopefully DCE changes that a little bit. It more directly applies to the individual physician. It's a program that makes sense. When you change your practice patterns, it very clearly affects your financial outcomes in a very direct way, in a very real-time way that doesn't have to factor into the business cycle for the hospital or the ACO or the HMO, whatever that organization is. So I'm curious if maybe DC lets physicians appreciate capitation in a different way.
Yeah, I mean, look, I sort of think of this as like hierarchy of needs, sort of kind of way of thinking about it, like the physician hierarchy of needs. And there's certain hierarchy of needs of running my practice, and financial stability is certainly one that has always had a lot of volatility, but certainly we've been exposed to much more volatility in the midst of the pandemic, and, you know, in-person visits dropping, a lot of clinical services, you know, being canceled, and physicians kind of looking around to see where they're getting their revenue from. And for all the folks who are out there, you know, who will say things like, well, the hospitals are eating up the physicians, and it's these big kind of provider groups. You know, you talk to anyone who's our generation about why they would sign up for a hospital-based gig. It's stability and it's the security. It's like I go to the hospital, I know I'm going to get a guaranteed paycheck, I'm getting my health insurance, and that stability and not having to worry about where the paycheck is going to come from is what allows me to engage in what I believe to be higher level work, which I can spend time doing some research. I can participate, you know, in this clinical trial. I can start spending more time with my most complex patients. And if we think about it in that sense, when I talk to younger physicians about why they'd want to go work for sort of a corporate entity, work in, some of them going into venture capital or investing, or why they'd want to go work for a hospital. It really is just that stability. And I think that if DCE is done right, it's not just DCE itself, it's this notion of creating that cash flow and stability, that once you do that, now the doctor actually has the ability to spend time on the things that matter for managing health at a population level, which I think has been the goal for value-based care from the outset, but has probably fallen a little bit short. Because even to this day, the best value-based care folks are really just thinking about their panel, their attributed lives. They're not really thinking about sort of the broader community that they're serving.
I think the secondary rationale for going into an employment construct or having your group be acquired, besides financial compensation and stability, is around the corresponding relief of administrative burden, that there are going to be larger administrative teams and the leverage that that scale provides, so that you as a clinician don't have to spend as much time dealing with your billing department or what have you. Does direct contracting do enough in that respect, or is it sort of a first step that we're going to have to evolve on as well?
Yeah, I would agree with you, Gabe. The administrative burden of starting your own practice, practicing independently is huge, and it's a huge detriment to why young physicians graduating today, or even mid-career or later physicians, are pushed to join some sort of larger structure such as a hospital or group. I think DC is the first step. To Ankit's point, it sets the financial stability piece in place to begin thinking about what else you can do on top of it. And the next layer there would be things like administrative complexity, things like patient demand generation, marketing, patient source, finding new patients, building your panel. And I think that there are ways to do that. Hopefully those are things that Pearl can begin to offer and begin to take off the backs of physicians, so that to Ankit's point, they can practice at the highest level and practice for the pursuit of providing good health care, working on complicated patients that need them and need their services, and not having to deal with these complexities that unfortunately the system has burdened them with over the past couple decades.
Well, there's always going to be a tension between administrative complexity on the one hand and the need for actually tracking the efficacy of care. And that,
yeah, I think there's always going to be like a tension in, call it, the transition period, right? I think the thing for the market, and I will say for Pearl as well, is how do we make that transition happen as quickly as possible and as smoothly as possible? But we're not going to sit here and pretend like there aren't bumps along the road when you're trying to shift from system A to system B. I think some of the frustration and I would say just mistake in the value-based care community is thinking that we can do this in an incremental way, right? So let me keep the original fee-for-service chassis, and then I'll layer on some quality measures, then I'll layer on a little bit of risk on this condition, and then I'll layer on a little bit more. And at some point you're just sort of like, I'm standing on two sides of the door, and at some point I just kind of got to walk through and get to the other side. And so, like, Gabe, I agree, like there's probably going to be some tension here, and this burden of these two systems will probably live on for a period of time. I think the goal for all of us in the community is just how do we accelerate the process so we're not living in that burden for too long of a period.
Yeah, I would agree with you completely, Ankit. I think the first generation of these models around quality or capitation were didn't fully appreciate the fact that it requires a significant mindset shift on the physician part, and it's a different way of thinking that is not better, worse, or harder or easier. It's just different, and it's hard to hold both of those, that fee-for-service mentality at the same time of thinking from a risk portfolio population health sort of view. And we all think about population health every day as physicians, but structuring your practice around it is different. And there's a lot of subtle differences there. The way you organize your staff, the way you schedule your day, the way you schedule patients for follow-up. And I think your point is a good one. You have to walk through that door completely and begin to restructure your practice. Not restructure, that's a strong word. Rethink the way you approach your practice to make it work.
For all of the things that we do to try to talk about, getting the right incentives, the right financial models for physicians, there have been multiple papers, right? And you talk to any physician, they know this. I mean, we talk a lot about this at Pearl, which is essentially this physician altruism, right? At the end of the day, physicians are trying to do the right thing. And if we can remove some of these barriers and allow for greater flexibility for physician altruism, even if I want to give my data science folks credit that, like, not every single decision that a physician makes is going to be right and perfect and sure, with a little bit of like, Monday morning quarterbacking with like data analytics and artificial intelligence, et cetera. Like maybe we could have made a decision a little bit better. But that to me ends up becoming a world we live in now, where the exception is now driving the rule. And if we could just create the space for letting physicians operate, we know that they operate altruistically with the best intentions, and they have the right training, we're more likely to see better outcomes in the aggregate. And again, I think this idea of capitation that direct contract facilitates is probably the best way to start harnessing more of the physician altruism that probably had like decades ago, but has probably been lost across all of the bureaucracy that we've layered in over the recent years.
Yeah, I mean, one of the things that's exactly the thing that I am most interested in the DC program is it provides that autonomy to physicians, and aside from regional variations in the financial model, ultimately it's not prescriptive on how you want to handle that capitation and what you need to do to make it work. Anki, the story that you gave me about the hospital in rural Maryland that during a heat wave gave out air conditioners to keep people out of the hospital. No program would ever come up with that idea, but a hospital that's in the community knows how to make that work. In the same way, the care that people need across different communities is very different, and physicians know that better than anyone. Giving them the flexibility to practice as they see fit to manage the total risk and the health of that population is the right way to do it. America is a very diverse, varied country with a lot of different patterns of disease and needs. And so hopefully DC begins to allow physicians to practice with that flexibility without being subject to the standardization that many previous government programs mandated them to have.
So Medicare, for the purposes of tracking utilization, and in part this is used to set future year benchmarks in the primary care capitation that a practice will get over time, they still want to receive claims from physician practices on capitated patients, and the value of those claims are just zeroed out. So you don't get reimbursed for them, but they're still useful for tracking purposes. And I guess my question is, well, in a world where between capitation, quality measures, and risk exposure, the physician is already sort of fully aligned to the outcomes of their patient panel and therefore incentivized to deliver good care. Is this, to Anki's metaphor, just to an extent, CMS sort of keeping one foot on each side of the door, and we'll see the Band-Aid be pulled off over time? Or is there real value that you think can't be replaced just through these incentives?
I think that a zeroed out claim is I don't think it's for the purposes of surveillance. Not surveillance is the wrong word. Sending zeroed out claims is for CMS to understand what is happening in the community. Ultimately, they're just Medicare beneficiaries. The government needs to allocate health resources, have public health systems, understand patterns of disease and things like that. And so I think in any situation, and even in other countries where physicians are operating independently and in a capitated basis, you still have some form of data exchange happening to understand the patterns of disease and utilization.
When I was at Medicare, everybody wants all the claims, right? Like the more data you get, the more analytics you can do, and that's what drives a lot of these kind of desire to create complex claims. I would bet, not surprisingly, that probably 20% of the claims rules drive 80% of the burden that cause physicians' heads to explode, right? Like, I just recently talked to a physician practice, and there's a Blue Cross plan that was auditing them. And like on a number of claims, they, added a J code modifier to like a 9921X bill, which caused a claim to be like kicked out for manual review. And the plan was trying to deny it. And the J code modifier was adding $2.50 to the claim. So like $100 claim. And like the audit process, the review, the billing, everything was costing like probably $5 a claim just to like review everything. And that I think that's the type of thing that motivates people to say like claims are just dumb and we should get rid of claims. And and like if that's what you're doing, I would agree with that. That's the stupidest thing in the world, that you would be like some ridiculous rule around J code modifiers, right? But at the same point, to like kind of Vin's point, when you're looking at public health, it's important to understand what the utilization patterns look like to get a grasp of what the health of the population is. We probably have just done a bad job of like making and managing that balance. And it's a classic sort of thing. Like one person, there's always someone out there who figures out a way to arbitrage the system, and then you end up creating a rule to prevent the arbitrage, and then that bad apple ends up messing it up for everyone. And I think we just need a better way of thinking about the right process for dealing with the bad apple, rather than sort of making the whole system suffer for that.
Well, thank you, Anki. Thank you, Vin. Really appreciate the time. And if those of you watching at home are intrigued by conversations like this, visit pearlhealth.com where we have more information and a new jobs page.